very much again for the opportunity to present to you, and in particular to the organizers and especially Dave for this opportunity. I have two disclosures that I'll speak about during the course of the talk. Those are the last two listed there. And how I'm going to structure this talk is to identify to you the unique issues and the concepts necessary to develop epilepsy surgery centers in lower and middle income countries, and base this on the experience of still doing this in the English-speaking Caribbean, taking you through the history of what we've done and the identification of the early steps to address the needs we saw, and then how we created priorities and then moved forward with what we had to do. But also to speak a lot about the hurdles that we faced and conceptually how we might move forward through these. So into history just before we started this initiative. In Jamaica, in the 90s, the majority of general neurology clinics were populated, if you like, by patients who had poorly controlled epilepsy. Most patients had CT, EEG, which then was just paper. It was usually not done because the newer technology of CT was thought to be superior to the old investigative tool of paper EEG. Most patients were given polypharmacy with the older drugs that are listed there. And stigma was enormously significant, with an employment rate in an audit that we did when we first started this of 15% for people with epilepsy, at a time when the unemployment rate for the rest of the population was high, but it was 13%. There were many superstitions, especially what we call obia in the Caribbean, which is, if you like, a form of voodoo. And there were no professional or layperson support groups for people with epilepsy. And there were very few neurologists and only two pediatric neurologists, no neuropsychologists or neuroradiologists. And so Bill Theodore reached out to me. I had just come back and said, as part of the global campaign, what about setting up a chapter of the ILAE? And so we created the first chapter of the ILAE, the Jamaica League Against Epilepsy. And this was the first organization that actually brought people together. There were people who were out there who were interested in epilepsy, but they had no forum or platform to work together in it. And immediately we saw that there was a need, of course, also to create a layperson support group. And so in the following year, we created the first chapter of the International Bureau of Epilepsy in the English-speaking Caribbean, the Jamaica Epilepsy Association. And I mention this because the JEA and the JLAE really had an enormously good synergy in the early days when it was just those two organizations. But you sometimes in your effort to create bigger and better things, sometimes you can stand in your own way. And when we created the Epilepsy Society of the Caribbean, which was the bigger chapter bringing 15 islands together, the JLA had to disappear because it was now no longer. It was subsumed, if you like, into the bigger, wider society. And then that synergy disappeared. And one of the big problems with that is that funding became difficult to raise because the synergy was so important for that. And of course, with the growing organization, size and scale of the organization, my own time became limited to do that. And the first hurdle and problem I want to pose to you that we have identified is that the Jamaica Epilepsy Association, even in its third decade, needs a lot more attention, and that has to happen. Then in my sojourn in the North American Commission of the ILAE, when Sam was the chair, we distilled and I should backtrack a little bit to say that the Epilepsy Society of the Caribbean and the Jamaica League Against Epilepsy, being were initially in the Latin American group, and it was felt, well, I felt that our needs would be better represented if we were part of the North American region, sharing a common language and also similar cultures. It's amazing how language can get in the way of relationships. And so I put this point forward as strongly as I could to the ILA, and fortunately they saw it the same way, and we were transferred into the newly created North American region that was Canada, the US, and the English-speaking Caribbean, well, initially Jamaica. And we distilled the initiative into 4 key objectives as listed here. The first is a sustained education program, which we call the North American Regional Caribbean Congresses on Epilepsy. And Dave and I have really worked on this from the beginning. Then the unification, as you know, of the region into one society, the Epilepsy Society of the Caribbean. The creation of a comprehensive epilepsy care program, including surgery. And a very important social issue that was a major problem in the Caribbean, and that is the outdated driving regulations, which had not been changed since 1938 in all islands of the Caribbean. And there have been, it's nice to dwell on one's achievements, and perhaps one can say what some of these are. There's growing community awareness of epilepsy as a physical disorder, and the indispensable role of EEG in epilepsy diagnosis, the importance of striving for monotherapy to limit side effects and to increase adherence was a crucial step forward too, and the important need for multidisciplinary care for people with epilepsy, and the role of video EEG monitoring for classification as an extension of the clinical method. And we started doing video EEG monitoring at Andrews Memorial Hospital in 2005. And really, it's been mainly about classification. And along the way, we've identified that something that was a big surprise to many of us, 13 minutes, was that so many patients had psychogenic non-epileptic seizures. And that was a very important factor in what seemed to be medication resistance. And failures, I put in inverted commas, a difficulty in retaining trained personnel, an inconsistent alignment of expectations with external partners. Maintaining inter-island cohesion has been a major issue because the Caribbean islands are spread out across a very large area. And of course, difficulty representing the Caribbean to external agencies, including funding agencies, given the great inhomogeneity, which I've called diversity among the regions. And when things stall, when alignments of interests change and priorities change, you can go through a period of a sense of failure and futility and a profound sense of aloneness at times. And sometimes you must step away and look for the big picture. And at a macro level, conceptually, it's about sustainable change. And change and innovation are not the same. All innovation is change, but all change is not innovation. And change can be difficult when there are reasons for maintaining the status quo. Innovation can occur as a single event, which is a disruptive change, or it can be an incremental advancement in which small steps are taken. And it's good to think about how entrepreneurs think whenever they initiate change. Entrepreneurs are motivated by change and to change things. Another important concept to think about is the issue of concept of social capital. Social capital is a public good that generates positive externalities for the achievement of common goals. And I like to think about a farmer who's near me who set up a bee farm, and in doing so, his bees have come over into my garden and have made my garden flourish. And so that's an unanticipated consequence of an initiative. And there are many good things that flow from good social capital. And really it's underscored by the fact that countries with greater egalitarianism have less variance in health. And the Caribbean is an unequal society because there are countries and also parts of the population that have means and others that don't. And this relevance is again underscored by US data, in which, as you see, there's a major difference in lifespan in males in the 1% and top and bottom 1% of the population. At a macro level too, operationally, how do you sustain what was done and the continuous changes that are required? Well, we tried for a while. Professionals working for free is unsustainable, and fee-for-service for people who don't have money. As I mentioned, the vast majority of people with epilepsy and their families are poor. And so nothing is free. Someone has to pay, but someone must be incentivized to pay sustainably for this to be a sustainable project. And you can look to charity, which we understand. You can look to philanthropy, which means a love of mankind. You can look to corporate social responsibility, which we understand as a benefit that a corporate structure has by doing something that ultimately benefits them too. And social entrepreneurialism, which is a concept in which a social entrepreneur identifies a project that he or she wants to address, one that has an enormous social implication, and in which the structure of the effort is organized as a business, and all profits are reinvested in the activity. People can make money, and people can be paid, but it is a concept that is a really important structure for doing things that are not driven by profit. At an epilepsy-specific and grounded micro level, I think we are evolving in a series of small steps towards a holistic model identifying actual priorities. And I've identified 3 in blue. One is a scalable epilepsy. We have to scale the way we diagnose epilepsy. The current model allows us very little scope to expand the numbers of people we can properly identify as having epilepsy. We have to increase access to a wider range of anti-seizure medications, including more potent anti-seizure meds, just so that we can reduce this population of refractory patients. And we have to identify psychogenic non-epileptic seizures more, because they are out there and they are contributing to that large pool of refractory patients. And video EEG is the only way in which we can properly do that. I have formed 3 ethical alliances with industry. The first is a company in Toronto in which we are looking through an AI-based platform to automate reading and reporting of EEGs in a way that we can scale EEG and to test this first in the Caribbean. We have convinced a major distribution firm in Jamaica and the Caribbean to form a Neurosciences division to expand the range of neurological drugs, and starting first with anti-seizure medications. This is an agreement we just signed last month, and we are looking to bring in an increased range of newer agents. And through the same company, they have agreed to support the program of long-term monitoring, continuous EEG in the ICU, and video EEG monitoring in the public hospital for epilepsy pre-surgical evaluation, because that's where it needs to be, not in the private sector. This is just a quick picture of some of my team doing continuous EEG in the ICU setting for subclinical seizures. Again, something that is may seem like a small and trivial step, but it is a major step when it never existed before, especially when you see the impact it has and the shortening of stays and the cost savings that happen. And to have a company walking with you on this journey with the money, and who will benefit too, because they are the ones who will have the chance to bring in more drugs. So critically in all of this is relationships for sustaining change. And this is where thoughtful stakeholder analysis is crucial. I put the state at the middle. We tend to put the patient at the center of patient-centered care. But I think when the state wins, the patient wins. and the physician wins, and industry gets to win along the way. And in a disparate area like the Caribbean, the new communication technologies that we have, even simple things like WhatsApp, has made a transformative difference in the way members of the team. And Dave has been amazing at bringing people together across the region to help, especially from a pediatric perspective. And Mark knows this very well. No one who's done an MBA can get by without knowing Michael Porter's 5 forces. And I think it's important to say here that one of the big threats has been the issue of opportunists and threats that come to the initiative, sometimes not with the intention to cause harm, but simply for themselves to benefit. And I've labeled some of these dabblers, and these dabblers can really create problems when it comes to you in your effort to develop a coherent, cohesive team approach to this problem. And the potential effect of all of this is the possibility of derailment of the entire initiative when things go wrong, or worse yet, or just as badly when the initiative fragments. So, with summary of these insights, starting something is relatively easy. It's sticking with it that's hard. Periods of reflection are crucial to understanding failures and getting going. No one person can do it all. Governments change. You have to change policy if you expect things to stick. Sustainability must be built into everything. Some require money, but this money has to be meaningfully spent. More money means sustainability, but funding must be sourced differently. And we talk about funding in business from being dilutive or non-dilutive. And succession planning has to be built into everything you do, and that's where mentorship matters the most. Again, it's evident that educational programs have to continue. I thought that we would scamper to the finish line of having a vigorous surgical program that was a hub and spoke, in which Jamaica would be the center of everything for the English-speaking Caribbean, but that has not been the case. Surgery has become fragmented across the region, doing lesions and lesionectomies and the occasional MTS and so on. And I think really now we're at the stage where in thinking it through, I think we have to prioritize the whole treatment gap rather than racing to a comprehensive surgical program in and only of itself. And I think, I've been really lucky for the last 18 years that Dave and I have been working constantly on this together. As I said, he's developed a vigorous network of pediatric neurologists and pediatricians throughout the Caribbean. Epilepsy surgery is a concept that that is now very understood, and the diet has been really taken off and has made a big dent on that population of patients who are, as I say, refractory. It's likely that pediatric surgical interventions will follow adult expertise building, but they can happen together. And certainly it needs to be. There's a huge pool of patients that are in need of care. Fortunately now, finally, we have pediatric and adult neurologists in training, and I think we may soon have the regional critical mass to be appropriately organic in how things happen. Dave and I recognize we are both catalysts in the end. It has to come from others, and that we alone can't do it. And in many ways, we are so alike. Moving forward, conceptually and operationally, the focus has to be on the treatment gap and outcomes. And a surgical program will have to be framed from a pragmatic economic perspective in which the real objective is reducing the treatment gap and improving outcomes. It has to be one part of a holistic approach, although one that should not be delayed if it's needed. Holistic approaches must be sensitive to local economies, realities, and culture. And we have to think differently about the surgical treatment gap, considering even new drugs like cenobamate because of how efficacious it seems to be, and considering neuromodulation such as VNS and other palliative surgeries as a priority rather than something that must follow failure of an evaluative plan that shows that the patient does not qualify for resective curative surgery. Technologies must be brought to bear, especially if they're not expensive. And these technologies should bridge gaps and lessen the requirements for everything to be at the point of care. Because there are so many things now that are available that can make it possible for us to do better things without them needing to be necessarily parked there. And technologies, including AI, must co-evolve organically with improving human knowledge and acceptance of these changes. And from an economic perspective, innovating to sustain equitable epilepsy care in lower and middle income countries starts with recognizing that the financial resources to do this the financial needs are increasing. Technology is expensive, and that new technologies are adding to that cost. And a sustained, well-thought-out plan supported by enhanced policies for philanthropy could support this bridge. Recognizing that philanthropy lessens taxation, lessens social tensions, and creates life-saving facilities for everyone, including the wealthy. And doing this must become a greater focus of governments in lower and middle income countries where it's not developed, where it's not well developed. And the question I ask you at this stage is, should the Caribbean Epilepsy Initiative be a social entrepreneurial model? And indeed, is it an investable opportunity? And I have this diagram of a macro model that guides me all the time in how I think about all of this, in which social capital, the intersection of social capital, policy, and innovation allow for philanthropy and social entrepreneurialism to sit at its nexus. All models are wrong, as one of my MBA teachers taught me. Initially, I conceptualized it as the problems of the Caribbean being disparities, distance, diversity, and detractors, and more recently, dabblers. But I think now we deal with this from how do we get more money? How can that money be more meaningfully spent? How can we match that to needs that are identified and align it to other needs that exist? How do we maintain motivation? How do we mentor to the extent that we maintain the momentum that's needed? And in my last slide, all lower and middle income countries are not the same. Some are reasonably financed, but lack human resources, in which instance cost reduction is not the issue. External mentors must be aware of local exigencies and sensitivities. There's great value in having a mentor from that country or region. The linear or algorithmic path culminating in invasive evaluations may need to be varied to accommodate local factors. Example, thinking about palliation earlier or thinking about palliation, especially lesser risk palliations like VNS, when curative procedures may not be possible because you don't have what you need to make that possible. Amplifying the availability of newer non-invasive investigative modalities makes epilepsy surgery more feasible and sustainable. Avoiding risks and costs of these types of invasive pre-surgical monitoring. The ultimate goal is improved outcomes. Not only seizure control, but a more holistic neurocognitive and psychosocial outcome with improved quality of life. And that's where multidisciplinary engagement is key. When training epilepsy personnel too, we simultaneously have to consider how you keep them, because we've had a problem with brain drain. And this has to be thought of from a financial perspective, how you get them involved in publications, how you recognize them for the work they are doing, and maintaining a social interaction with peers and mentors, which is what the NARCI did so well. Epilepsy surgery is vastly underutilized even in developed countries. So a financially sustainable, organically developed, technologically relevant and customized approach, i.e. a viable business model, is essential in lower and middle income countries. And I want to just end with my last slide in which I want to make this point. When you make that big decision to go back home after training, it changes from an exciting idea to a lived experience. All of a sudden you are all in. And I have to give thanks to so many people who've been involved in this journey with me, especially Dave, and also to so many other people at home. Thank you.
All right, those are great talks, guys. Is Dr. Gonzalez-Martinez also on? Okay, okay. Dave.
Yeah, so two quick questions for two different individuals. That was great, Amza. Conceptually, in my mind, and we have discussed this, low middle income countries are very different from small island states, which may have higher income, but health economically is low middle income. I'd like you to speak to that a little bit about the Caribbean, because as you said, all is not equal. So they have sub-countries that are racing ahead, some others not, and the interconnectivity isn't there. That's one thing. Now I'll just ask the second question, and sit down. The second question is, at a different level, where we have discussed things, our friend and Jorge, for the quote-unquote palliative techniques, or whatever you want to call them, most of the outcome discussed is at 7 to 10 years. Many of those papers don't talk about other interventions. Speak to the concept of not giving up, and if you do one procedure, you may have to do another. So I'll take Amza's answer, then I'll take the other.
Thanks, Dave. You've put your finger on what has been a major issue for us in the Caribbean, which is the islands are not all the same. Some are big, some are small. Some have large populations, some have diverse populations, some are high income. So islands like Antigua, where Dave is from, and St. Kitts are high income countries by World Bank standards. And then, but they, not so much Antigua, but an island like St. Kitts has basically no personnel for epilepsy care. And then you have islands like Jamaica, which are upper middle income by WHO definitions, and have a fairly high concentration of expertise, but don't have the financial resources that you need to take you to the next level. And so, there's everything in between on the spectrum. And so how do you keep people working towards a common goal in which their priorities are different? In a small island where you don't have EEG and a routine EEG, their priorities are different from Jamaica, which has continuous EEG monitoring and video EEG monitoring, MRI, and PET, and so on. But the priorities and how those resources are allocated and how you get governments to buy into a concept that is regionally unifying is an extremely difficult thing. And Dave and I have realized that we have to work through CARICOM, which is the overarching body of the Caribbean community that can influence policy in all of the different territories that it represents. And so we're really going up now to the top to change policy.
Okay, yeah. So thank you very much. That's a great question. I think, yes, if you look at, if you follow somebody for 5 or 10 years, you cannot just hold on the other treatments or provide them the benefit of the other treatments. Those are available. So there are so many confounding factors. Even in these studies, I just mentioned you as the neurostimulation techniques, but there is in the background. Many of them had the surgeries just prior to or at the same time. There was part of the lesion removed, and then the rest of the lesion was stimulated. So that part of the lesion, how much of that was contributing to the epileptogenic zone and how much of the lesion left is contributing, these are the factors which we don't know. And I think, yes, it's a multimodal approach. That's why I think it's not like you can hold one treatment from the other or you can say one is superior. That's why I compared all three. If you look at their 7 to 10 years numbers, the numbers look same. But they have different mechanisms. They have some, for example, RNS have provided you, yes, cure in very focal seizures, which VNS never provided or provided to a lesser extent. So yes, they become seizure free. if particularly in the eloquent cortex. So combining the different techniques is the key. And even if you have like providing treatment with one technique, whether it is a surgery, corpusculostomy, you should think about bringing the other one to help them in the long term. Because if the first techniques decrease their seizure to 50% and the second can add a 10% more, that's a benefit to the patient and it should go to them.
You know, I can speak to neurosurgery a little bit in the English-speaking Caribbean. Again, being a friend of Dave's, and we took care of a number of kids from the Caribbean together, I would go down to Antigua with them. And one of the things that is very interesting in the English-speaking Caribbean, there are neurosurgeons in Jamaica, and there are neurosurgeons in Trinidad. But the whole Eastern Caribbean, there are none. So if someone, in Antigua is a fair amount of people, it's about 80, 90,000 people. If someone in Antigua needs a neurosurgeon, they either die, or if it's a more chronic condition, one of the neurosurgeons from Trinidad or Jamaica will fly there. But, and this is not disparaging at all, they will not get off the plane unless you hand them a check for $30,000. Or the patient will get transferred to Cuba or Miami. And so I kind of learned this firsthand on one of my trips with Dave. Dave's working away, doing all these EEGs, and I'm like sitting by the pool at the hotel. And he calls me up and says, "Bro, do you have scrubs?" And I was like, "No, why?" And he goes, "Well, there's a patient that is a friend of the Minister of Health in the hospital that they want you to see." I said, "Well, I don't have a medical license." He goes, "Well, you do now, you know." So anyway, we went there, and it was a prominent DJ, very popular in the island, and he had a chronic subdural. And they were talking about, you know, the $800,000 expense of sending him to Miami. So, you know, we did a burr hole and evacuated, and he did fantastic. But, you know, why wait? So, you know, that gave me a lot of ideas, which I could talk about endless. You know, Amza and I talk about how do you provide neurosurgery coverage for the Eastern Caribbean, and it's not the traditional model, I don't think. There's just not enough neurosurgeons where someone goes and lives there. But it may be more like a super locum tenens where you have a roster of 20 neurosurgeons who go there for a week or two, but it's 24/7 coverage. And we started those discussions with the Minister of Health, but then the Hurricane Marie hit and screwed up everything economically. But anyway, please.
Okay, so my question was for Dr. Gonzalez. Hey, Salim from Fort Worth. So I continue to grapple with this patients who you are looking for the seizure onset zone in the dominant temporal lobe, and basically you need stereo EEG, but you are still kind of in fix with their language localization. So in those cases, I know you alluded in your last slide about bringing them back and doing subdural grid, and you keep on seeing in literature people talking about doing cortical stimulation for language localization in stereo EEG patients. So how are you grappling with that? Like what percentage you will bring them back, or do you use any kind of particular paradigm where you are going to do the subdural versus use the stereo EEG for language localization?
Yeah. So thank you so much for your question. It's a very important question. So the way we handle those patients is the following. In general, we are able to really define the extension of the EZ and the overlapping with the eloquent cortex, specifically for posterior language areas, by analyzing very carefully the seizure semiology with SEG electrodes. So what I'm trying to say is that in general, a lot of patients that we believe we are operating the dominant side, but in fact, when we see their seizures, the speech disturbance occurs so much later on the patient's semiology. I mean, the seizure starts, and then after 10 milliseconds, 15 milliseconds, and then they have a speech disturbance. That means to us that the epileptogenic zone is very distant from the primary language areas. And in general, when we do those type of resections, of course, with the functional mapping with electrical stimulation, we in general don't need to perform any additional mapping of the language. So again, the semiological features is for us, the semiological evolution of seizures is for us the best functional mapping you can obtain for those patients. However, when we have very close proximity with the posterior language areas, like that case that we illustrate, an area dominant hercial gyrus, very, very close, with involvement of language disturbance or language changes soon after the onset of seizures. And then this is the case where we would like to have a better, more fine definition of the language versus the easy. We attempt to perform those patients with an awake procedure. And if we cannot perform that adequate mapping with awake for whatever reasons, for anesthesia challenges, for cooperations, patient is too small, that's the case where we decide to, as a plan B, to implant a subdural electrode, map the language areas extraoperative, and then take the patient back for a safe resection. I have to say that this is it's more an exception than a rule. In our case, we're able to perform the mapping and the definition with SEG and with careful analysis of the semiological features. But in some very, very few cases where we really don't know what is the interface, we consider to put subdural grids as two posterior language areas. For everything else, we don't perform subdurals. We perform mapping with SEG and with electrical stimulation and with analysis of the semiology.
Awesome. Thank you.
Could I just
Welcome. Thank you for the question.
Yeah, Dave.
No, I think that's great. Just for one quick thing, after Milliard and the paper came out in 21, we've been trying to use SEG, as you suggested, Jorge, in both expressive and receptive language for mapping. And in our pre-surgical planning, we tend to try and place electrodes in and around then with contacts. And it's been amazing in that some of the contacts that are a bit deeper will actually get language, whereas the superficial contacts, as they alluded to in the paper, that we would have had with subdurals would not get it. So sometimes pending placement and proximity, the SEG does language mapping quite well.
Yeah, absolutely. I just want to emphasize that whatever we have in terms of functional mapping with subdurals or electrical stimulation, this data is not validated at all, right? So to me, it's troublesome to evaluate like a function like language by electrical stimulation in an organ that is an electrical, it works with electricity. So that means that whatever you stimulate that area, the effects that we produce, it may be distal to the areas that we stimulate. So this data is not validated at all. So that's the reason why when we perform the analysis with the SEG, we do have the opportunity to really understand what are the changes in that particular area in the cortex and see what's happening with the patient during that time. If you see changes in that particular area in the cortex in the baseline with epileptiform activity, and you see the patient, when you examine the patient has normal language, that area is not involved in language. So that is the different concepts about doing a functional mapping with SEG versus with directly electrical stimulation with subdurals. We take into consideration the semiological features caused by the changes caused by the in situ epileptiform activity in that particular area in the cortex. And this is, to us, is superior than electrical stimulation in that area because of the reasons that I mentioned.
Great. Yes, please.
I just have a quick question. So we know that globally the healthcare workforce is not well distributed with more highly concentrated numbers in urban areas versus rural areas. How can we incentivize staff such as nurses and epilepsy educators to work in underserved areas?
That is a huge question. I think some of this might come from the individual themselves. Their own drive to do this is important. A network that they may have within that country or area, a network of friends or professional relationships, that tends to help. And on the other side of it, the value that that country sees or that organization sees in what you bring, and that should be commensurately, rewarded. It's a very, it's easy to say that come and help. People should come and join the fray, but it's okay for a 2-week visit, but anything that really makes a difference, it requires an enduring commitment to it. And so, in a sense, it's reciprocal. Both sides need to find a way to make this happen. But it's a really great point you're bringing up, because there are many people in North America and so on who want to do things somewhere else. And it can be a rotating system of support too. And these are all the kinds of things that we are thinking about now. I know it's also about training people, come down to train people and leave that as your legacy when you go back. And maintain contact from afar. Yeah, there are so many ways that can be important, yeah.
That's terrific. This is a great session. Thanks for everyone's attention. We're going to go on a short break, about 10 minutes, Dave? 5? No break? 5-minute break, because some people got to go to the bathroom.